Okay, all set, Melissa?
Yep.
Okay, perfect. So, excuse me, good morning. You should have all heard an automated announcement that this meeting is being recorded. Per Governor Lamont's executive order, all public meetings must be recorded or transcribed and made available to the public. Therefore, in order to ensure a quality recording, I ask that everyone please mute their phones at this time and remain muted unless you wish to speak. Also, to assist in making the recording more clear, please announce your name each time you begin to speak. So now we'll go through and do some introductions and we'll take attendance. So just a quick good morning to everyone. I'm Nicole Godburn, Fiscal Manager for Reimbursement and CON with the Department of Social Services. So going through attendance, Barbara Cass.
Present.
Lita Orfici.
I am here, thank you.
Matt Barrett.
Hi, good morning. Matt Barrett is here.
Judy Dowd. Judy, I see you're here. You're on mute, but we'll count you as present. And Mag Morelli is excused for today. Mairead Painter.
I'm here. Good morning.
Michael Morris.
Good morning. I'm here.
Claudio is on vacation, so he is excused for today. Senator Moore. I thought I had.
I'm here.
Oh, perfect.
Oh,
Thank you so much. Representative Abercrombie. Senator Berthel. Representative Case. Senator Daughtry Abrams. Representative Steinberg. Senator Summers. Senator Wong. Representative Pettit.
Present.
Thank you. Good morning. Senator Austin. Representative Walker. Senator Minor. And Representative France. Okay. Oh, actually, just admitting. Oh.
He does that, then it's bad. Hold on 1 minute. I got to put myself on mute.
Okay.
Good morning, Senator. Now going through distinguished guests, Commissioner Gifford. Commissioner Jatani.
Present. I'll be leaving early just to let you know, but thank you.
Thank you. Deputy Commissioner Aaron. Bill Halsey.
Good morning. Here.
Good morning. And Dan Lerner. Okay. Now going through folks that we have not yet called. Let's try to make this easy. So we'll start kind of at the top and I'll just kind of call out who I see. And if I miss anyone, please let me know. I see a phone number 1-860-384-1328. Could you just announce your presence?
Good morning, Lisa Conley, Chair of Leading Age, filling in for Mag.
Oh, thank you so much, Lisa. Betsy.
Good morning, Betsy Boyvid with DSS.
Thank you. David Dearborn.
Good morning, Nicole and all. Thank you.
Melanie Dillon. Melanie, I see you're on mute though, but good morning. Jonathan Fink.
Good morning, Jonathan Fink with CLA representing Leading Age Connecticut.
Great. Thank you, Jonathan. Larry Santilli.
Good morning, Nicole.
Good morning, Larry.
Good morning, Nicole. This
Yep.
is Melanie. Sorry.
Hi,
I couldn't
Melanie.
unmute myself before because I couldn't figure out my mouse.
Good morning. Thanks for joining. Nick Mazzato.
Hi, Nick Mazzato with DSS Reimbursement and CON.
Good morning, Nick. And I think we have, oh, Sue, I'm sorry.
Oh, good morning. Sue Mosman, OPM.
Perfect. Thank you. I think that's everyone. Did I miss anyone?
Hi, Nicole. Just
Emily
Owen Root
Shepherd,
from
Blessing.
OPM.
Oh, Owen Rude and Emily. Good morning to both of you.
Also, Brandon Whitburn, OPM.
Good morning, Brandon. Okay, perfect. I think we have everyone. So to kick it off, I will start with our agenda, which the first item on the list is the right sizing plan submission update. Just a quick reminder for everybody, as you may recall, nursing homes submitted plans to the department that were due to the department back in April. The department went through those plans, took a look at them, and have crafted a final report, which we have posted and published to the DSS webpage. I've dropped in the chat the link directly to where the report is posted on the DSS website, so folks can click on that link and link directly to that to read that report. So it is posted, it is public, it is live, and I guess open up to questions if anybody has had a chance to review it, has any questions. I know this was a much anticipated report, so I have to imagine that there are questions. None? That's surprising.
Well, if it's all right, I'd like the opportunity to comment.
Sure,
not
absolutely.
necessarily
Questions, comments? Yeah, I completely open the floor, Matt. Thank you.
No, thank you so much, Nicole. First, I want to express, our association's gratitude to Commissioner Gifford in directing this really thorough analysis. I think the agency has really impressively, sort of sliced and diced the data that was presented in the April 1st plans. And Nicole, you very graciously gave us an advanced briefing of the material. And I had the opportunity to say that to you and your staff in that meeting, but I wanted to express it publicly that this is really quite impressive work from the department and your division in terms of categorizing the responses, putting it into visual charts and so on and so forth, and candidly in expressing the department's opinion on where nursing homes were not as responsive as the department had hoped for, in their April 1st submissions. And so we applaud the agency for this work. We look forward to continuing to work on right sizing and rebalancing initiatives informed in good measure by this, what we kind of view as a scan, an April scan. We're not quite to the other side of the public health emergency and the pandemic, but I think we came to the view that it was important to get a scan of where we were in April, even as public health officials are cautioning us about a fall resurgence of the virus. We think we're so much better positioned than we were in, say, the spring of 2020 to in so many different ways, almost in every way, including we have the testing that has been made available and supported by the government. We have the PPE we didn't have. We have made great strides on infection prevention and control. We've received financial support from the Lamont administration and the Department of Social Services, and so on and so forth. And so we're in a much different place, even with a potential increase in the virus for our Connecticut nursing facilities. So we think it's an important scan. We did, publicly express that we don't know exactly where we're going to land in terms of our occupancy, as we get to the other side of the pandemic. There are very positive signs that our occupancy is moving towards almost full recovery. Now, we can't predict the future. Prior to the pandemic, we were 89% or 88 to 89% occupied. And at this point, we're almost 81% occupied, noting that the national occupancy is 74%. And so we're scores above how the rest of the nation is doing in terms of its occupancy recovery. Nevertheless, this is important work to be doing. I think we hold to the view that we will not have the exact same size nursing home industry, bed-wise or maybe facility-wise, on the other side of the pandemic. So this April report is a really important sort of baseline, if you will. But we look forward to updated numbers, perhaps in the fall or even into 2023, to really understand where we have landed, noting that Connecticut is one of the oldest states in the nation. The sixth oldest, based on the I don't mean oldest in terms of the Constitution. I mean the age of our population, our over 85 population in particular, is among the oldest in the nation. Sixth, according to the U.S. Census. But anyway, thank you for the opportunity to comment, and look forward to continued discussions about the April 1st efficiency and right-sizing plans and ongoing conversations, dialogue about right-sizing and rebalancing initiatives. Thank you.
No, thank you, Matt. And just to point everybody in to the DSS website, we do post monthly census documents to our website. So I'll post that link in the chat, but Matt is correct that current statewide occupancy in Connecticut for nursing homes is just over 41.29%. So we have been ticking up slowly as we get further out from COVID. So I'll post that link for folks if you'd like to reference the census reports. And then I see we were also joined by 860-930-5694. Could you just please announce yourself?
Oh, hi, Nicole. It's Ken Frisbee.
Oh, good morning, Ken. How are you?
Oh, good. Thank you. I couldn't get in, so I'm on the phone.
Oh, perfect. Oh, thank you for joining us today. So any additional comments, questions regarding the report? We, of course, are happy to take questions offline. So if folks have not had a chance to review the report and have questions later on, we're happy to have those conversations.
Nicole, Bill had a quick question.
Yes.
If maybe for Matt, or he said occupancy at 41, 42%. In a global sense, where do we stand in terms of employment, nurses, aides, etc.? Most places at 75%, 80%, 90%, or are there still major holes in terms of coverage right now?
I'm happy to take that, Nicole, with your permission.
Yeah, no, absolutely, Matt. And just my apologies if I misspoke. Statewide, we're at 81% occupancy statewide. But the employee question, though, yes, Matt and folks from Leading Age, I completely, or Larry, if you'd like to chime in and chat about how you're doing on staffing.
Sure. Let me
I feel better at 81. I thought I heard 41. I thought, man, I've had a mini stroke in the beginning of this thing here, because our nursing homes look like they're pretty full.
No, we're up to 81. We were at 70 something before, but our biggest problem right now isn't the occupancy issue, which we're in a full agreement that we should right size our homes. The issue is the labor costs, and there was a bill out there, the cap pools, that went nowhere. Some pools are charging $80 an hour for a nurse's aide. So we made an attempt, but we didn't get the support. So right now our costs are up, and we filed them. We gave a sample of our homes. They're up 22% on labor costs, 22%. This is the worst labor shortage I've ever dealt with. And it's not getting better by any means. And that's the problem we face more than the occupancy. The occupancy issue we can do as a team and right size our homes. We can't create nursing or the lack of pool use At this point, when the pool comes in, they tell our staff what they're getting paid and everything else, and they start recruiting their own staff. So it's a war, and I said that a long time ago. I think on one of the calls a couple months ago, and it's a war that we're losing right now. So,
Yeah. Larry, if I could add too that the Dr. Pettick's question about staffing, we have tried our best to compile some staff occupancy rate analysis. And we think that our vacancy rates, staff unfilled positions, is as high as 40%. Now, not everyone has 40% vacant positions, but we provided we evaluated a sample of nursing facilities and found we have as many open positions as 40%. And I think it's really a relevant question as it relates to occupancy, because we see a strong connection between the ability of our nursing facilities to staff up and to take new admissions from the hospitals. And we continue to have weekly meetings with our hospitals over their concerns that nursing facilities continue to deny requests for admission. And the principal reason, or one of the principal reasons, is they just don't have the staff to take the new admissions. Number one, they can't provide the quality of the care that they want if they're have too many residents versus the number of staff in their buildings. But number two, we run afoul of longstanding federal and state rules regarding providing care to our residents if we take admissions that we're not able to address their needs. So we think the 80% number has kind of an artificial component to it, or a distortion to it, and that were it not for our staffing issues, we actually believe that our 81% occupancy percentage would actually be much higher. I don't know exactly when I'd be grasping at a number, but we think it's considerably higher than 80 if we take the staffing factor into consideration.
And a follow-up, if I may, Bill Pettit again for Matt or Larry. Are we back to pre-pandemic pace in terms of short-term rehabs for hips, knees, TIAs, et cetera, people that come in for a week or two and move out quickly, or is the staffing issue preventing that from occurring on the discharge end at the hospitals?
Yeah, Larry, I'd really appreciate it if you took that provider-specific question. You're still on.
Sure. Well, and again, it'd be nice to have the hospital's input. But what's happening is, especially on weekends, the hospitals are backed up with those type of cases, Bill. Because again, on a Saturday at 5 o'clock, we don't have staff to take admission, quite frankly. So the weekend activity is very minimal at our homes. During the week, it picks up. But the hospitals were backed up with COVID cases. We as an industry took the COVID cases. Now they're backed up with complicated cases like vent, bariatric, that need specialized care. We can't staff our regular, quota, 7.5 on nurses' aides and 10 and 15. So how do we help them with these complicated cases? And I know Matt and Nicole have been working together on that. But once we do get rates and everything else, where do we get the staff from? Where do we get the respiratory therapists from for vents? Where do we get? We've got to face reality. We are in a crisis right now, and it's not just us; it's the hospitals too. And it's Johnson Memorial. A lot of these hospitals are having issues staffing their buildings, and they pay more than we do. We are getting results, but it's costing us $10 an hour for a differential for a nurse's aide. That puts them up to $32 an hour. That's helping, but then the 7 to 3 is like, okay, if you're paying them $10 or $12 an hour or more to work 3 to 11, what about us? So it's just a ripple effect, and it's just. I think if we cap the pools, we would have an ability to do it. I know it's too late for that, but without capping the pools, it's a vicious circle.
If I could ask a question too, based on Dr. Pettit, this is Kathy. And what I'm trying to, I understand the worker crisis or worker shortage that we have in job classes relative to nursing homes, group homes, hospitals. As a matter of fact, in anything relative to nursing in facilities within the state, like the Department of Correction or any of the other facilities that need nursing. Has the nursing home industry been in touch with the Governor's Workforce Council? Does anybody know?
I think I can characterize, we've had some preliminary reach out conversations with the council, and we do see some really positive work going on, initiated by Governor Lamont in the area of workforce development, training opportunities to intervene earlier with incenting future workforce, reaching out to the high schools and technical training opportunities and so these are terrific long-range opportunities, and I believe there's initiatives in place for tuition reimbursement and other sorts of support or subsidies for this workforce. And so we're very supportive of all of that, and looking forward to these ideas becoming more concrete for skilled nursing facilities.
And this is Lisa Conley. If I can just, add to what Larry said about the admissions for new or short-term rehab, addition to the points that he made, we're further encumbered with admissions that come in that are either unvaccinated, not fully vaccinated, or fully vaccinated but are COVID positive. And especially for our nursing homes that have very limited private rooms, it completely changes the dynamic of our ability to fill our beds because of cohorting or isolating. So just wanted to bring that up. That COVID continues to be in our space, and so we're still dealing with that at this time.
Yes, this is Senator Summers. I'd like to ask a couple questions, if that's possible, to Matt and to Larry. I've spent a lot of time at some of our long-term care facilities and assisted living facilities in Eastern Connecticut, all over Eastern Connecticut, even just as recently as last week. And there are some situations now that are, I would call it, classified as beyond critical, where the patients are, I would say, receiving inadequate care because there's just not the staffing, and we have directors of nursing working 90 to 100 hours a week, and other assisted living facilities are saying, hey, Heather, do you know any nurses? Because I'll give them $1,000 bonus if they refer me a nurse or somebody who can work, third shift on the weekends kind of thing. I had one assisted living facility say if a nurse refers another nurse, they'll give her a $5,000 bonus. That's how desperate it's become in certain areas. So I would like to ask you if you could give us, as legislators, what are the top 3 things that we could do as legislators to help you through this crisis? Obviously, it's a crisis across all healthcare. My husband's a heart doctor. He sees it every day. But for the immediate and then long term, would you be able to give us 3 concrete things that the legislature could do for the immediacy, and then again moving on to longer term?
So, and if I could, I'm sorry, back to the question that I posed on the Governor's Workforce Council. This is Kathy Austin. The Governor's Workforce Council has $70 million in training dollars. It also has dollars for helping out with tuition reimbursement and other things. So I'm curious, because we know that this is a national problem for the workforce relative to nurses. Is there a way? Would you be interested in? And I like Heather's idea of our top 3 things, but the fact is that this is a national problem. So how do we address this? Back in World War II, the president declared it an emergency for nursing workers and did the Cadet Nurse Corps. Are we at that stage where we have to do something nationally is my question to all of you. And are you getting dollars to help out recruiting or getting nurses from the Governor's Workforce Council? Thank you. Apologize for interrupting.
Well, through you, Nicole, with your permission,
Oh, of course.
I would absolutely say that a national intervention should be on the table. And I know that the American Healthcare Association, who we're affiliated with at the Connecticut Association of Healthcare Facilities, is advancing those ideas in Washington. And I think there's a promise, or there's a strong hope that Congress will eventually act. It's not really a nursing facility specific workforce crisis. It's really a healthcare crisis across hospitals, nursing homes, and in home care. When we talk to our colleagues, we're all experiencing the same such of issues, and we have to look at the system as a whole. And so support across the entire system, and a national intervention is absolutely needed. Along the lines of, you could say, some of the issues that Connecticut is once again showing advanced leadership on, and kind of being a test or an incubator on, and tuition assistance, and some of the workforce development issues that we had mentioned in the Governor's Council that are percolating now. But yes, absolutely, a national, and I'm happy to provide the council and Senator Austin, especially, some of the detailed proposals that are in Washington, D.C. on workforce.
Matt, would you be able to send that to all of us? That would be really helpful.
Yeah.
And, if I can follow up with Senator Austin, one of the things that that has come to light is, we're supposed to train. We need to train more nurses. There are more people that would like to go into nursing. I have had people suggest, do you really need to have? Why can't we institute more programs in the high school? So when I was in high school a long time ago, you could get your LPN in high school, because there's just not enough availability of programs. We don't have enough teachers to teach the nursing programs. Not Three Rivers has a huge waiting list locally, or UConn. It's very competitive. There's just not enough slots to get these folks trained. So if we look to offer something at the high school level, let's bring back that intermediate LPN that's not really highly used anymore, because they can be just as good as an RN. They don't have a 4-year degree, but they're trained in a way that we used to use them all the time. We had a great legislator, Lenny Winkler, who was an LPN. She worked for years and years. So if you could give us some concrete ideas for, the immediate need, because I see it as beyond crisis level in Eastern Connecticut in long-term care, and then longer term, what we can do. That would be really helpful. I know it's a national issue, but I'm obviously focused on Connecticut. So what we could do here in Connecticut.
Matt, and if I could request that information that you'll be gathering for everyone, if you could send that through Melissa, that way she can message that to everyone who's on the call, so everybody gets the information. We can all review that, and also suggest that we should probably put staffing on the agenda kind of as an ongoing item for our future meetings for this, since this is obviously very much an issue, so that we can continue the discussion. So I don't want to close the discussion, but just Matt, if you could send that to Melissa so we can get that to everyone, and then let's just stick staffing on the agenda so we can keep discussing. And Marie, recognizing you have your hand up.
Sure. I just wanted to point out, we've been working with the Workforce Council. We have residents who feel that there is sort of a bias or a stigma to working in long-term care, and that people, especially since the pandemic, haven't been engaging in the same way. So we've been talking with them about doing a campaign with the residents, highlighting who lives in long-term care. This is what it looks like, trying to destigmatize that a little bit. And they want to engage as much as possible because they want to see the staffing better as well. And we've had a good response from the Workforce Council on that, and have been getting regular updates. So trying to work with I think it was to Senator Austin or Summers' point, the colleges, maybe linking up residents from those local communities to go in and talk about who they are, who they'd be caring for, and kind of break down some of those barriers and stigmas.
Just one more thing, Nicole. So in order to win our battle with the pools, and that's what it really comes down to, because as you know, the workforce has been shortened by COVID. People do not want to come back in. And no matter what we do, it's going to take time for that to happen. And we are doing a lot of things. We're increasing the rates and everything, but it's not always all about money. What we have now going on is we have a lot of our staff getting burnt out, working 2 shifts, 3 shifts, DNSs, covering weekends and everything else. So in order to make up for the staffing shortage, we're burning out our own people. And then we have the pool coming in with their higher rates. It's a disaster. And I'm sure Barbara could talk about, the homes on weekends with their staffing. The only solution short term is to get some relief for these homes. They're not going to be able to continue to pay out 22% when they're getting 4 or 4.5. That can't continue. And there are funds that you have available, which are the emergency funds. I know that, that we have for the 10% that we had through June 30th. That stopped because our census went up a little bit. I understand that completely. And I also think we've got to right size our industry as a team, work together. And like I said before, we're in full favor of that. You need both though. You need to right size at the right number. The right number is once you have enough staff to take residents from the hospital. So whatever that number is, if you have homes that are way below that number, we've got to find a way to get them right size, help them out or whatever the case is. But the staffing, you could be at 95% occupancy. You're paying out 22%. How do you survive? And it's not even working because we're still using pool. So I think we need immediate relief starting this July for our staffing crisis, like you did for the revenue shortage that we had. There's definitely a need. We've shown the need. So, and this is, again, this may go away in a couple of years, but right now we have a way to pick up a lot of that staff that went to the pool and bring them back home. So.
Yeah, Larry, and actually that's a good segue into just a really quick reminder for everyone and for nursing homes that there is 10 million in ARPA money available for nursing homes. And we just posted that detail to the DSS website. So I'll drop the link in the chat. So nursing homes are asked to complete an application or complete an attestation document. That 10 million was divided up among the homes based off of what would be the equivalent for a temporary 10% rate increase for the month of June. So the nursing homes would get a lump sum payment of that $10 million. And so homes would just have to complete an attestation and a short period cost report, return that to the department, and then we will issue the funds to you. Funds will be issued the week that we receive the returned attestation document. So we will be getting that money out the door weekly as we get the return documents to us. So just a reminder that that 10 million is available, and I'll post that link in the chat. And just reminding nursing homes to come in and complete that documentation and get that back to us. Okay, and I just posted that direct link for everyone. So I don't want to truncate the conversation on staffing, but in the interest of time, moving on, and we can of course circle back to this, but moving on to Lita. And if you have any updates on survey activity and quality.
Thanks, Nicole. So I just wanted to give everybody just a quick overview of where we are at DPH, sort of where we're headed, and what I hope to see in the next meeting. So as you all likely know, Barbara Cass retired as of June 30th. Big loss to us and the state. Donna Ortelli also retired. You'll see that Barbara is on this call because we enticed her back as a temporary worker retiree to help us with the transition. So she is particularly helping us focus on recruiting the leadership team, both the section chief, that's Donna's position, and her own position, as well as helping us transition out of what I've been, sort of euphemistically calling the COVID chaos down in facility licensure into sort of the pre-COVID, back to normal times kind of work. And so what I mean by that is, as you all know, during COVID, our regular work like surveys was suspended for a period of time. We did a big focus on infection control surveys, lots of testing work, things like that. And during this time, we also, like the rest of the healthcare industry, experienced, a certain amount of turnover, which has been exacerbated by the recent retirements. What they call the silver tsunami in media reports of all the folks who left state government in June and just before. So having said that, we are in the process of right-sizing our own regulatory function. We're bringing on, we should have 15 new surveyors on board by the end of the summer. We're actively recruiting additional surveyors and others, as well as Barbara and Donna's group. That we do still have a very strong core staff of surveyors on board, and we are working to make their schedules a little bit more predictable, both for them and for the industry as we choose to go out. So I just wanted to give that backdrop. I think in future meetings, we'll probably have some data to share. We are trying, now that we're sort of coming out of the COVID days, we're getting back to some more regular metrics and things like that, so we can share that in the future. I asked Barbara to join us for this meeting to talk a little bit about what we're seeing specifically on quality issues. No one, I think, here will be surprised that we are seeing quality issues in the facilities, largely driven, we think, by the staffing shortage. But let me turn it over to Barbara to give a quick overview.
Thank you, Lita, and good morning, everyone. So I typically, during this quarterly report off, give the number of significant survey findings that we've had. And our focus over the last couple of years has really been on the number of immediate jeopardy situations we've identified. And this past quarter, since April 1, we really are at an unprecedented number. Since April 1, we have had immediate jeopardy in 9 different nursing home facilities. And they, as Lita has mentioned, there is a nexus between staffing, the issues or quality of care issues that we're identifying are related to inadequate staffing in the facility and supervision of staffing. There have been issues with abuse and neglect. We've seen a fair number of significant med errors that have had significant findings or significant outcomes to residents. We've seen issues with choking and elopement in nursing homes as well. So I think as I describe some of the high level issues that we're seeing, I think you can see that there is a connection to the staffing and access to workforce issues that nursing homes are experiencing. So I will stop there.
I do just want to add that as we look at these cases, so I think it's a little bit too easy for us to say, there's staffing issues and that explains staffing shortages and that explains the problems we see in nursing home, and that's kind of inevitable. So as Barbara said, there is a nexus, but one of the things that we are seeing are things that are in fact avoidable. So just because you're short-staffed doesn't mean you abrogate your responsibilities, that nursing homes, abrogate their responsibilities for training their staff appropriately. What it does mean is that if you've got a lot of new staff coming in, or you're using a lot of contract worker staff, you do have to pay a little more attention to regular training. And so some of what we see on these IJ cases and other types of findings are failures to appropriately train staff, orient them to the policies, and then failures to do the oversight of new staff. And so, you know, I don't want to leave the impression that, okay, we've got staffing problems and that, you know, staffing shortages, and then inevitably we're going to have quality issues. There is a certain amount of this that is about, you know, managing new staff appropriately, because what we are seeing are things that, you know, could be avoided. No question staffing is an issue, but you know, we have been encouraging, we'd like to encourage the industry to pay, you know, more attention to the training obligations, particularly when they have buildings that have high numbers of contract staff. So I just want to make sure, you know, even if you're working with a smaller staff and a smaller census, you should still be able to, you know, meet your quality standards. So that's sort of how we're looking at it.
And Lita, the only thing that I would add there, that as a regulator, I don't historically get to proclaim, so that while we've had 9 facilities that had immediate jeopardy situations, we've also conducted upwards of 30 to 35 investigations that did not have those significant issues. So I think it's important to note that staffing, many facilities are able to cope with the workforce issue. And while it may not be a perfect world, we're not seeing these outrageous significant findings that rise to the level of immediate jeopardy in those upwards of 30 to 35 other investigations or nursing homes that we've surveyed.
Yeah,
So,
I think that's a great point, Barbara. And we're also seeing that, by the way, you know, let's not forget, we still have a COVID pandemic going on. And so there is still COVID in buildings. And I would also like to add that I think we've been pretty pleased to see how well most facilities are managing COVID outbreaks that are continuing to happen. And so that's a real, you know, that's a real testament to how the industry and the workforce has acculturated to the kind of infection control standard that, you know, we all have to have in the healthcare settings during COVID. So yeah, you know, we agree with that. And Barbara, thank you for raising that. I think that's an important point.
Bill Pettit here, Alita and Barbara, the issue of getting back to staffing, you seem to indicate that more of it had to do with training / orientation, or is some of it due to, because there's such a need for help, that you're getting people with lower levels of experience and competence accepting positions? Are you seeing any of that there's a sort of a lower level of skill in the people that are being hired given the work shortages?
Dr. Pettit, I don't know if we've made that observation. I don't think we can say unequivocally that it is related to the experience or drawing from a bench that doesn't have the experience. We have said for my 22-year career at DPH that when we identify these significant issues, there is almost each and every time a link to failure to supervise properly. We had a branch chief here who used to say, and Matt may remember this, take away the offices of the supervisor. They need to be out on that floor. And that was the best advice anyone could give any kind of a healthcare facility. And again, that's where the supervisor may be in place, and the supervisor with lots of experience, but isn't on the floor coaching and asking what support they can give. So back to Lita's point, I think it's really drilling down that training message that it's all hands on deck.
Thank you.
Great. Any other questions for us?
So Lita, sometimes I can't help myself. I just want to go back to Dr. Pettit's question or comment that I think with some of our nurse aides, the temporary nurse aid program, we've seen lots of value in that program because it gave an individual who may have been looking, thinking, exploring a career as a nurse aide, did the temporary nurse aide program, and then we built a bridge with the industry and at DPH with our nurse aide training program. So we saw that as being a great value add in preparing the CNA or preparing an individual for that CNA role. And they had time as a temporary nurse aide. They transitioned into the nurse aide program and came with good experiences. I mean, I can't say that for every nurse aide that has passed through the doors of a nursing home, but we saw that being a value add to the training that we could collectively partner on. Sorry, Lita.
No, good. I'm glad you added that.
Okay, all right. Thank you, Lita and Barbara. So moving to the next item on our agenda, receiverships, closures, and bankruptcies. So since the last time we met, we have had no new receiverships. We still have one building in receivership, but we've had nothing new, no new closures or no new bankruptcies. So not much activity to report there. Next, an update on the case mix transition. So as a reminder for folks, we transitioned our Medicaid reimbursement to an acuity or case mix reimbursement methodology that went into effect on 7/1, July 1st, just 13 days ago. So that went into effect. We are currently with our unit in process of drafting the rate letters, which will go out to nursing homes the last week of July. So that nursing home should expect to see their rate letters coming out shortly. Over the past year, we've been providing shadow rates to the nursing homes so they could see how their rate would change under the acuity reimbursement system. So nursing homes have been provided with that information, but the system is now in effect on July 1st. So any nursing home that has a question or concern, more than happy to come to us and have a discussion. They're still receiving their shadow rate reports directly to the nursing homes so they can see how their rate will fluctuate under the case mix system, and they can be able to track that. We will be hosting Matt, Mag, and the department. We will be hosting a series of seminars and kind of stakeholder meetings, because part of the acuity-based system is we're going to be incorporating a value-based component to acuity that will help to support and reward nursing homes that are doing a very good job of improving their quality. So that component of the system will go into effect on July 1st of next year. But throughout the course of this year, leading up to next July 1st of 23, we will be working with the industry and having stakeholder meetings to discuss what a value-based component to acuity will look like. So I believe, Matt, the first of our conversations, I believe, is next month, but we will be having those discussions and we'll be able to kind of report out on that and status. So we'll be able to report out through this meeting on how those are going. So we look forward to those discussions. If there are no questions, or I don't know, Matt, if you wanted to chime in on the value-based.
Well, thank you very much, Nicole. I always want to begin by expressing our gratitude to the department. The transition or behavioral change to a case mix component in the Medicaid rating system was quite a change that, for Connecticut. Rates have always been a cost-based perspective set, and the acuity of Medicaid recipients was never a factor in the rates. And so that we had a really managed and thoughtful phase-in process, and really probably an unprecedented stakeholder input process directed by the commissioner, I think has well positioned us to make this transition with ease. And that's what the feedback I'm getting from our facilities is the notion that they've had months of providing sort of data and input regarding their case mix indexes, and that has led to the translation of a shadow, not implemented case mix rate. So when we sort of hit the toggle switch on July 1st, and there were even corridors put into place that prevented any enormous losses. We refer to them as stop losses or stop gains. And so, and then we have a 3-year phase in. I think is impressive, and I think it's the way to manage a process. And it sounds to me, Nicole, that you've expressed that the commissioner envisions a similar process as we move towards value-based payment system incentives in the rate setting system. And all I can say is we really look forward to beginning those conversations. And we really had sort of a test, or not a test, but if it weren't for the pandemic, we really began these value-based conversations signaled by the commissioner, a few years ago, but they were really necessarily, I think, delayed or, due to the pandemic. So I think that moving towards resurrecting that, I think the timing is just perfect for that, and we look forward to that.
Thanks, Matt. And I posted in the chat a link to our acuity-based webpage where for folks who are interested in seeing the actual model. It's a very large Excel spreadsheet. You can actually see how the acuity system, the rate calculation works. We've posted that. We also have detail posted about the phase-in. As Matt mentioned, acuity will be phased in to help minimize the financial impact of the nursing homes. That will be phased in over a 3-year period. So you can see the phase-in plan and what that will look like. So our webpage does have a ton of information, lots of detail. And if folks have additional questions about how the reimbursement method works, feel free to reach out to us, and we're happy to help support and answer any questions. So opening it up now for other business. So this is kind of the point in the meeting where we kind of open the floor, and if folks have questions, concerns, if folks want to touch back on something that was said previously, this is kind of the chance for everybody just to kind of, I don't want to say a free for all, but just an opportunity for everybody to kind of ask their questions and or concerns or make any statements. So opening the floor. So seeing none, which is surprising. This is usually a very robust group.
I'd only comment that perhaps the reason why the open forum at the end has some silence to it is because of the robust conversation that had occurred under the previous agenda items, and we always are grateful that the industry has the opportunity to be recognized and express its perspectives. And I couldn't really say it any better than Larry had said earlier on, that the towering figure, the figure that towers above all issues, he characterized it as the worst he's ever seen in his 40+ years of operating, is the staffing related issues and the costs associated with, or the consequences and costs associated with these staffing issues related to the pools, and that these costs are just not reflected in the underlying rates that the nursing homes currently receive. And so we really appreciate the opportunity to have, to be able to express those points of view. So thank you.
No, thank you, Matt. And I agree that this is an important topic to discuss. So we should probably add this for our agenda for the next meeting to further discuss staffing and get status updates and see how things are going. So. Okay, so seeing nothing further, making a motion to adjourn.
So moved.
Perfect. All right. I think we're good. Melissa, any other housekeeping or? Oh, you're on mute, Melissa.
We are all set. Have a great rest of the day. And I believe we meet again in October.
Yes.
Okay.
Perfect.
Bye.
Thank you all.